Okay, we already start the recording. So, okay, so Dr. Hiew, you're here. Okay, so Dr. Hiew is here. Okay, so then we are going to the second part. So basically, today, thank you everyone for joining us. We're going to have another interesting call lecture and class today, as usual, and we hope we learn a bit more on neuroemergency. So today we are very lucky to have no other than Dr. Hiew. Dr. Hiew Fuliong is basically going to share with us about Myasthenia Gravis crisis and its management, what emergency physicians should know. So a bit called introduction about Dr. Hiew. Dr. Hiew is a neurologist currently working at Sunway Medical Center. He is called very senior neurologist, consultant neurologist, has been involved with a lots of neurology specialty training program, lectures, so neurology, neurophysiology, neuromuscular disorder, and he's also previously respiratory registrar and research fellow in the Queen Elizabeth Hospital, Birmingham, UK. So Dr. Hiew currently is a member of Nature Neuroscience Society, Peripheral Nerve Society, and International Society of Apharesis. Dr. Hiew has published multiple research articles and has great interest in inflammatory neuropathy, Guillain-Barré syndrome, CIDP, chronic inflammatory demyelinating polyneuropathy, anti-MOG and neuropathy, and inherited neuropathy, Charcot-Marie-Tooth, and more. So there's a lots of other called neuropathy. So he's the expert today. So without further ado, the floor is yours, Dr. Hiew.
Thanks, Ashraf. Just let me share my slide first here. Okay, can you hear me and can you see my slides?
Yes, can. Yeah.
Okay, good. Thanks, Ashraf. Thanks, Neuro Emergency Specialist Group for inviting me to speak. Thanks, last Rina for approached me to speak again for Neuro SIG. I was given the topic today on Myasthenia Gravis and what to do basically from the emergency physician point of view. So I'm not sure how often do you guys see Myasthenia Gravis, but I think it's not rare. I mean, although it's in many places it's considered like a rare disease, but it's actually not that rare actually. All right. So, okay, good. This is the outline of my talk, and I'm going to speak to you with regards to Myasthenia Gravis, and just a brief introduction, and explaining to you how the immunopathogenesis of the disease, which is very relevant to its clinical subtypes, and I'm going to tell you what myasthenia crisis is and how it presents itself. And in some rare circumstances, you do see some of the patients with myasthenia crisis that refractory to treatment. And very briefly, I will touch on the role of thymectomy. And finally, I will just give a quick conclusion from the talk today. So myasthenia gravis is actually an autoimmune disease where it is considered as an autoimmune mediated, conditions that acts on the neuromuscular junction, which the main so-called the pathognomonic presentation of myasthenia gravis is actually it causes muscle fatigability. The prevalence of the myasthenia gravis is around 20 per 100,000. It is not that rare and it's not that common, but you do see them quite often, whether you are from the ophthalmology specialties or whether you are from the general medical society specialties or whether you are a neurologist. So the incidence is about 20 per million populations. Of course, for the younger patients that are less than 40 years old, women are more common, 3 times more common than men. And for the older, we call it the late onset myasthenia gravis of above 60 years old, men have a higher incidence compared to women. So you can see from here on the red box, this is what the neuromuscular junction is. It's basically a physiological connection between your nerve and also your muscles. And this is where the problem is when you have myasthenia gravis. So myasthenia gravis is very, very related to the presence of antibody. So these are the antibody that is directed against the neuromuscular junction, and there are various different forms of antibody in myasthenia gravis, and the most common one is what we call acetylcholine receptors antibody, where it is actually present in about 85% of the populations. And for those that have negative acetylcholine receptors antibody, part of them have anti-MuSK, which is a muscle-specific kinase antibody, and rarer antibody including LYP4, which is the lipoprotein receptor-related protein 4 antibody, arginine antibody, and some of the antibody actually acts against protein in actually the intramuscular antigen protein. So just briefly, just let me get my laser pointer. Okay. So what this antibody is it is actually forms of abnormal antibody produced by your bone marrow or produced by your thymus, where it actually acts on what we call the neuromuscular receptors protein. So these are the protein what we that is present at the neuromuscular junction, including what we call the acetylcholine receptor, and you have the arginine protein here, the LYP4 protein here, and the MuSK protein here. So these are the protein antigen that is present naturally in the neuromuscular junction. So your body actually produces the antibody that acts against all these antigen and causes this neuromuscular junction to become malfunction. So the precise origin of the autoimmune response in the neuromuscular junction disorder, including myasthenia gravis, is unknown. It's not precisely known, basically. So it involves what we call activation of complement MSC over at the neuromuscular junction site, and because of that, it actually caused disruption of the neuromuscular acetylcholine receptor function, and because of that, it causes what we call a functional block. It's not actually a physical or damage to the junction. No, it's just because there's a reduced number of acetylcholine receptor for the neuromuscular junctions to accept impulses from the nerve. But having said that, although most of the patients will have an antibody in myasthenia gravis, but up to about 12% of the patient is still what we call a seronegative myasthenia gravis. So what I mentioned just now is when you have this kind of abnormal antibody, it also causes what we call a complement activations over the neuromuscular junction, and it causes what destructions of the number of the acetylcholine receptor, and at the same time the formation of membrane attack complex. It actually damages the post-synaptic membrane, okay, of the neuromuscular junction. All these eventually cause the reduced density of the acetylcholine receptor, and no matter how many acetylcholine neurotransmitter that you can come out from the nerve, it does not attach to the receptor to cause the muscle contraction. So this is basically the pathophysiology of acetylcholine receptor positive myasthenia gravis. So what about the MuSK antibody myasthenia gravis? So this MuSK is actually part of the bigger molecule in the neuromuscular junction that is actually responsible to what we call aggregation of the acetylcholine receptor. This protein itself responds in getting all the acetylcholine receptors arranged nicely on the neuromuscular junction. But when you have an anti-MuSK antibody or anti-arginine and also LRP4 antibody, it should disrupt this process of aggregation of the acetylcholine receptor. And due to that, again, you have got less receptors in the neuromuscular junction, and therefore resulting in neuromuscular junction disorder, and one of it is myasthenia gravis. All right. So the pathogenesis of the myasthenia gravis itself is actually very heterogeneous, and there are multiple factors that determine, the presentations and the outcome, the response to treatment in the patient with myasthenia gravis. So one of it is presence of thymus or thymic tissues in the mediastinum. Some of the thymic tissues are normal. Some of them don't have a thymic tissue. Some of them have a hyperplasia of the thymic tissues where they are not malignancy. And actually, some of them, up to 15% of the patient with thymic tissues is actually thymoma, which is a form of neoplasm. Other than thymic tissues, your age, your association with genetic, your HLA association also actually affects how you present. Whether you present at the early onset, for example, for those in the Asian populations, or whether you are presenting as a late onset myasthenia gravis. So, so all these actually are involved in the overall presentation of a patient with myasthenia. So the classical presentation is fatigability. So in a patient with acetylcholine receptors positive myasthenia gravis, so you get this what we call a fatigability, which is actually the fluctuation in terms of muscle weakness. That as you put more efforts, you do more activity, it can become more and more obvious and more fatigue. So some majority of the patient will present to you with ptosis or partial ptosis. Some of them can have diplopia, dysarthria, swallowing difficulty, and breathing difficulty, facial weakness, and where they typically have this myasthenia look, where they are a bit motionless, and then they have arm and also axial body weakness. And again, all these worsen with exertion, worsen with more activity towards the evening. But other antibody myasthenia gravis, for example, MuSK, which is the muscle-specific kinase antibody, have a slightly different presentations, where the main targets are actually your bulbar muscles, where it resulting in difficult in your speech, your volume, your voice, and also your swallowing. And they are more towards the respiratory muscle, where it causes more breathing difficulty, dyspnea, and also reduced effort tolerance. And some of them also have what we call upper esophageal muscle and also paraspinal muscle involvement in a patient with muscle-specific kinase antibody. And again, the involvement of the eye are less compared to those with acetylcholine receptors positive myasthenia gravis, right? So the clinical subtypes can be, just ocular, where they remain just ocular myasthenia gravis for the entire of their life. But many patients present with ocular myasthenia gravis, but within 3 to 4 years time, they progress into a generalized myasthenia gravis, where they involve respiratory muscle, bulbar muscle, they involve your limbs as well. Again, they will have a higher risk of developing myasthenia crisis. And some of them have, as I mentioned earlier, you have early onset, late onset, or very late onset myasthenia gravis. And some of them have thymic, and some of them have different antibody profile. So again, it's a very heterogeneous kind of presentations. And of course, there are many factors, as I mentioned earlier, that determines how a myasthenia gravis patient will actually present. So this is the interesting data that was published probably about 20, almost up to 15 years ago. The lifetime course of myasthenia gravis since humans first discover this disease. So if you can see from the green chart, so from 1940s, where we first discovered myasthenia gravis, to about the year of 2000, the number of patients with the myasthenia gravis condition or the symptoms or their severity actually improved over time, because of course you have more medication being discovered, you have more immunosuppression, we learn how to use steroid, and we know how to treat patients with myasthenia crisis. That's why you can see that the overall condition of the patient actually improved. But however, when you look at the number of patients who died, of course, with more medication that came out in the 1940 and 1950, you see that there's a reduction in terms of mortality. But since the 1950 to 1960, you do not see a very dramatic reduction in terms of patients who died from myasthenia gravis. This means that the overall mortality of the myasthenia gravis patient has not changed for the past almost half a century. So what does that mean is patients still die from myasthenia crisis, and patients still die from the complication of the myasthenia gravis. And you see the number of patients who goes into remission. Of course, nowadays we have got so many different types of treatment. We have got steroid, we have got immunosuppressant, and then we have immunomodulator. But over the years, there's no significant improvement in terms of patient that goes into complete remission. Of course, the definition is very heterogeneous nowadays. in terms of what do you mean by remission, whether you are pharmacological remission, whether you are actually completely in remission. But overall, what we are interested for today's discussion with regards to myasthenia crisis is the number of mortality is still not significantly changed. Okay, so how do you define myasthenia crisis? So actually, this is actually I don't think there's any definite definitions of how you should classify a patient that has myasthenia crisis. So some classify it as a life-threatening manifestation of myasthenia gravis, where it necessitates a certain form of ventilation, whether it's invasive or non-invasive, supported by tube enteral feeding, and also the need of ICU management. So when you have this criteria where it involves breathing, swallowing, and also need ICU support, you are considered as someone that have myasthenia crisis. But other definitions include, where you have a severe myasthenic weakness that require intubation within the next 24 hours, and some actually define it as weakness from myasthenia that is severe enough that necessitate intubations or ventilator or airway protection. Whether you need ICU or don't need ICU is not part of the criteria. Again, you do see some patients who define it as the need of hospitalizations to monitor respiratory status or severe dysphagia that requires enteral and parenteral nutrition. So even without actual need of you intubating the patient or giving ventilator support, as long as you have this deterioration in terms of your respiratory and also your swallowing status, you already consider as a myasthenia crisis. So again, there's no fixed definition. So what are the standard, more established definition that we use is what we normally refer to the definition from the International Consensus Guideline for management of MG, where the myasthenia gravis is divided. Definition has actually two different portions. One is what we call impending myasthenia crisis, where it is defined as a rapid worsening of myasthenia that could lead to a crisis in days or weeks. For example, I mean, it's a little bit vague in a way. So you kind of like, when you have impending myasthenia crisis, means that you're going to predict that this patient is going to deteriorate into myasthenia crisis within the next 1 or 2 weeks, or more. So as long as the patient have this deterioration in terms of myasthenia gravis, you can consider them as impending myasthenia crisis. And the other section is what we call a manifest myasthenia crisis, where there is a status of the patient already requiring intubations and also a non-invasive life support, regardless whether you actually need a tube, NG tube feeding or not. It's not really that part of the criteria. But if you're requiring respiratory support, whether intubation or non-invasive respiratory support, you are already considered as the myasthenia crisis. So of course, this definition excludes those people, those myasthenic patients that goes into, you have an elective surgery and then post surgery you keep the patient intubated, but they are not part of the manifestation of the myasthenic worsening condition. It does not fit into myasthenia crisis. There's a separate, entirely different issue. So the lifetime of a patient with myasthenia gravis who need intubation or mechanical ventilation due to myasthenic crisis is about 20 to 30%. So typically it occurs within the first 2 to 3 years from the disease onset. And the annual incidence of myasthenia crisis among all the myasthenia gravis patients is about 2.5%. Of course, you see them more among the elderly, and up to a third of them will actually have a recurrent myasthenia crisis if they have experienced once of myasthenia crisis incident. And in some of the cases, if myasthenia gravis, they have never had symptoms of myasthenia gravis before. And the first presentation of myasthenia gravis is actually a myasthenia crisis that occurs in about 13 to about 20% of the patients. So again, not necessarily that a patient must have a myasthenia gravis before in order for them to be diagnosed with myasthenia crisis, because some of them, they do present themselves as the myasthenia crisis, even though they were perfectly well before this. So what happened in this? What happened in terms of the physiology and also a pathogenesis of a patient with myasthenia crisis? So it actually leads to a respiratory muscle weakness, and subsequently the reduce in terms of the respiratory volume, your respiratory function, and this is due to the weakness of your upper airway, sometimes even your bulbar muscles, causing obstructions, and also your weakness in terms of your intercostal and also your accessory muscles, and also the diaphragm that cause your lung expansion to reduce. So these are basically the pathophysiology of a patient with myasthenia crisis. So what it causes is, with the reduction of your chest expansion, with the weakness of your bulbar muscle, it actually causes a microatelectasis inside the lung, and subsequently in terms of reduce its lung volume. So what happened when the patient experiences microatelectasis, it actually develop, trying to compensate at an early stage. So they breathe rapidly, more rapid, and then they have more shallow breathing. And initially, when you look at the blood gas, they develop respiratory alkalosis, and then they blow out the CO2. And although they are still, maintaining a normal PaO2, but as they go and as the weakness becoming more severe and the patient becoming more fatigued, they develop type 2 respiratory failure, where the CO2 start to raise, and subsequently they develop hypoxemia. And this is where they decompensate. So when they decompensate, the only way for you to treat them is to give them respiratory support, right? So this picture is not my patient. I got it from Google, so it's just to let you know that patient's privacy. But when you are appearing in Google, I think I can just copy it into here. So the diagnosis of myasthenia crisis require the establishment of a history. They can have history of myasthenia. Sorry, the typo there. They have a known diagnosis of myasthenia, or as I told you, some of the patients that comes to you might not have a history of myasthenia gravis. So the history from the A&E physician should focus on whether they have any infection that can trigger the myasthenia crisis, and their respiratory symptoms, what drugs they are on, and whether they are actually adhered to the treatment of myasthenia gravis. Majority of the time, when the patient go into crisis, there's nothing much that you can ask, in terms of history. Sometimes you just want a very brief one to tell you, a rough idea of the diagnosis and how the patient do as they go over the next couple of hours, where they're going to deteriorate. So your main aim is actually to establish the diagnosis and making sure that they are not decompensating. So in terms of the neurological examinations, you can see that some of them will have ptosis, and they have diplopia because of the ophthalmal paralysis. So they have this facial muscle weakness. They don't have much of the expressions, and sometimes they can't even open the jaw. They can't even close the jaw completely because of the weakness of the jaw muscles. They have dysarthria. They have hoarse, bulbar kind of speech. They have difficulty swallowing. The salivas are just drooling because they just couldn't swallow the saliva properly, and sometimes they even choke and cough because of poor cough reflex from the throat. Neck flexion is very important because your neck flexion is actually directly tells you how strong your diaphragmatic strength is, and also it gives you an idea that when the patient started to have neck flexion weakness, you're going to watch them very, very closely for a respiratory decompensation, because neck flexions actually correlated with the diaphragmatic strength. Looking at how they breathe, their muscle breathing patterns, and paradoxical breathing is a bad sign. And sometimes their chest expansion are very, very shallow, and that these are the group of patients that is going to go into decompensation. And for those that can still speak to you, and for those who are relatively well, you can ask them to monitor what we call a single breath test, where you ask the patient to take one breath and count loud, 1 until 30 until 50. Normal patient can actually at least count until more than 30 or 40 without needing taking the second breath in between. But in a patient that have got myasthenia gravis crisis, they can't do that. You monitor the vital signs, your blood pressures, you monitor the oxygen saturations, and so I was mentioning to you the neck fracture. It is a very, very important sign that I routinely use in assessing all my patients with myasthenia gravis. It's because your neck flexion itself is actually controlled by your upper cervical nerve root. As you know, your diaphragm as well is also controlled by your upper cervical nerve root innervation. People always say your 3, 4, 5 keep you alive is because of your diaphragm. So when you know that when the patient starts to have the neck flexion weakness or neck extension weakness, you know that the cervical nerve root is actually involved. And these are the patients that will potentially go into crisis if their weakness actually extend even further. So it's a very, very good sign. And of course, some of them you can test the shoulder girdle elevation and also the shoulder abduction. So these are the tests that you can do to tell you roughly, okay, how good is this patient at the stage when you assess them, right? Emergency physicians also will need to look out for the concomitant infection, looking at X-rays, whether they have atelectasis, aspiration pneumonia, and of course, not all the patients with myasthenia gravis come to you with difficulty is because of myasthenia crisis. It can be due to some other thing. For example, pulmonary edema, heart failure. There are many other reasons why the patients can develop difficulty in breathing or fluid overload if they have heart or kidney issues. Bedside spirometry is something that is not routinely available in many hospitals, and only certain hospitals have the facilities. You measure their forced vital capacity and you monitor it. But some of them I see in a smaller hospital, they do not have the facilities of doing spirometry. They actually monitor the peak flow. It is not a standard recommendation, but if you have the facilities, you can monitor the vital capacity, but it is not like a must thing that you do. Look for the source of infections where it is very commonly the trigger for myasthenia crisis. Do a septic workout, check the metabolic electrolytes abnormalities. ABG, yes, it's good for you to decide whether this patient is what is the oxygenation and also the carbon dioxide status of the patient. It helps you decide whether the patient will require a ventilation. But however, it is not useful to diagnose crisis. All right, it's not something that you look at the ABG, oh, this patient is in crisis. No, because myasthenia crisis is actually a clinical diagnosis. There's ABG will not be able to tell you such a condition. In bigger centers, especially for the patients that have got no myasthenia gravis before this, and you do not know whether this is the first presentation of myasthenia crisis, you want to do other supportive tests, for example, serial antibody for myasthenia, and also electrophysiology tests. But this is not routinely available, in A&E, and it is more to a center with a specialized care. Okay, again, first from the A&E, we need to rule out other differential diagnoses. I think earlier speakers and also Ashraf also described some other causes of a patient having respiratory insufficiency that require intubation. Not everybody comes to A&E with respiratory condition requiring intubation is myasthenia gravis. You rule out other conditions. From the neurological perspective, you might want to consider whether this patient have a young Guillain-Barré syndrome, whether this patient have a Lambert-Eaton myasthenia syndrome, or if the patient has got a history of progressive weakness, upper limb and lower limb, suggestive of motor neuron disease, these are the patients can also present as a decompensated respiratory conditions where require intubations, and of course some of the very aggressive inflammatory myositis. Similarly can cause proximal myopathy, just like myasthenia gravis, and require ventilation as well, because some of the inflammatory myositis actually develop pulmonary fibrosis, and they eventually they go into decompensation. Other non-myasthenic causes of respiratory dysfunction include pulmonary embolism, heart failure, as I mentioned just now, ARDS, COPD, bronchiectasis. There are many other causes why that can mimic the presentation of myasthenia crisis, especially in the patient that have never have myasthenia gravis history before. Okay, common triggers, as I mentioned, infection is of course the most common. Pneumonia is the most common. Sepsis, aspiration pneumonitis. Okay, and from the clinical experience, from your practice experience, you know that a lot of patients are non-compliant to the treatment. So if the patient diagnosed to have myasthenia gravis and you told them that you need steroid, you know, they freak out. They essentially freak out. You give them the steroid, they bring home, and the steroid stays there forever. And one day they decompensate. They come to you with decompensation of myasthenia gravis. But for those who very aggressively want to treat the patient with myasthenia gravis after the initial diagnosis, and then when you put them on steroid initiation of a high dose of steroid, and high dose of steroid is actually a cause of a trigger for a patient to go into myasthenia gravis, especially when the dose is more than 40. If you diagnose someone today with a myasthenia gravis and you want to decide to put them on the steroid, you put them slow, go slow. Start them on 10 milligrams, and after 1 or 2 weeks, 20. You know, if they are remaining stable, you just gradually taper it up. Don't start high. When you start high, 40 milligrams, you can tip them into myasthenia gravis. As what the previous speakers mentioned, neuromuscular blocking agent is also one of the causes that could precipitate myasthenia gravis, especially for those MG patients that goes to the OT and they require general anesthesia for some other reason, you know, for some other operations, and it can potentially trigger a myasthenia gravis. And if you were to look at the whole list here, even emotional distress, when the patient distressed, they go into crisis, the doctors also distressed, and not because you need to sort them out. So this is one of the quite a common, you know, it's not really that uncommon to get patient into emotional distress and go into decompensation. Of course, some of the patients you can never find the cause why, and there's no obvious precipitant. They just go into crisis. So what I want to show here is the medication pitfall, because you might see some of the patients in A&E with myasthenia gravis. They come to you with some other problems, okay? And when you put them, they are not in crisis, they are very well. When you put them on medications, you always need to warn them that, you know, if this medication causes you to have weakness, you know, and this patient cause problem, you stop it and you come to the hospital. So the first one is try to avoid the use of beta blocker. This is one of the very common medication that could precipitate patients with myasthenia. Of course, I mentioned about steroid before this, and the use of macrolides antibiotic, especially azithromycin and erythromycin for some atypical pneumonia. You can use, I'm not saying that you can't use them, you can use it with caution. You want the patient that, look, I'm giving you this antibiotic, but this antibiotic might potentially cause some weakness in you. So if you experience that, you please come to the hospital or you stop it. This is something is very, very important. Because why you want them to do that is because you want them to be aware of, you know, the potential problem with the medication. You know, they're becoming weaker, they not keep on taking, then they come into you with crisis. And also statin, all right, something that is so commonly used. Of course, it is not something that you contract. It is not something which is absolutely contraindicated, but it is something that you need to monitor when you initiated them some statin in some of the patients, because statin is so widely used nowadays. So from the international consensus on guideline, they also recommend the cautious use of live attenuated vaccine, in the patients with myasthenia gravis. Of course, when we don't give live, we don't normally give live attenuated vaccines nowadays among adults. Sometimes we nowadays probably just give you some COVID-19 vaccine. When it first rolled out a couple of years ago during the earlier phase of pandemic, we also all worried that whether this COVID vaccine is going to cause myasthenia patient to go into worsening of their condition. But what we see is it doesn't really happens now. Okay, all right. But in fact, for COVID itself, actually, one of the reasons why they decompensate than the COVID vaccine. Right? So the goal of the treatment with myasthenia crisis is to immediate management of their airways, their respiratory, and also the circulatory support. Later on, you confirm the diagnosis of myasthenia and also myasthenia crisis, evaluate and treat the acute respiratory failure. You identify the trigger or the precipitating factors. You initiate treatments, immunomodulatory therapies, and then you give other treatments for further prevention and also the treatment of complications that might come once the patients have a myasthenia crisis. So in terms of management, of course, as I mentioned earlier, you identified the possible precipitant of the Myasthenia Gravis exacerbation, and most of them will require intensive care setting, whether it's ICU, HDU, depending on how severe the myasthenia crisis is. So the mainstay of treatment is respiratory management. This is something that is very, very important, because only when you secure the respiratory function, only you can make sure that they get through the entire treatment of the myasthenia. If you don't stabilize the respiratory, the treatment of the myasthenia, it could take some time to work, and they go into hypoxia. All right. So I was mentioning to you FVC monitoring. This is something that probably some of you do, but not all of you. But if you happen to do this, especially when you are in a specialized care unit, just to let you know that your vital capacity for a normal person of normal height, okay, is probably about 2 to 5 liters, or 3 to 4 to 5 liters. This is the normal patient's forced vital capacity. So you can see from here, if this is patient 1, the first patient, if for this is patient A, so it start on the 1st of May with 2 liters, and then subsequently it downs to about 1.3, and then it go up to about 2.4, then it go to about 1.4, and then subsequently stabilized at around 2. So are you worried of this patient? No, normal patients, your first vital capacity is about 4, 5, or even 3 to 4, 5. And then this patient comes with 2, and they never improve over the 3 days duration. So in fact, when I look at this kind of chart, I'm not worried. Although the patient have a low vital capacity, but over the last few days, you can see that they are not actually deteriorating. At least they are stabilizing. So these are the patients that probably will take some time to slowly respond to your treatment. And you can still monitor them closely. If they are not going into decompensation, then they might not need ventilation because they're relatively stable, although their forced vital capacity is kind of like low. But what is more worrying is if you see a second patient with, although a very high forced vital capacity from the very beginning of 3.6, but as you monitor, even at the 3rd day, you can see that the forced vital capacity is still relatively good, 2 to 3, 2 to 5, the kind of thing. But you can see that this patient is gradually deteriorating. So these are the patients that you want to put more attention, because when you monitor the forced vital capacity, it is not about the value, it's about the trend, how the trend goes as you monitor them. And although you can see that it's relatively pretty good, as compared to this patient. If I'm comparing, same height, same sex, same, same age, but you can see that the declining trend is one that is more worrying. Okay. So intubate and ventilations. If possible, we try to avoid emergency intubation. I think this one everybody knows about it. You want to electively intubate them. You want to prevent them from aspiration. You want to secure the airway. You don't want to go into decompensation. I mean, of course, it's ideal, all right, but not every time things are ideal. You probably have to face in some of the cases where you have to make an emergency decision and to do an emergency intubation. So intubation is generally indicated if the patient going into respiratory distress, where they're becoming more fatigued, they're increasing tachypnea, and that the tidal volume is coming down. They're becoming breathing more and more shallow. They're going to decompensate. These are the patients that will need intubation. They develop very severe bulbar dysfunction. They couldn't manage the secretion. They have a very weak cough. They couldn't swallow the saliva. They are drooling it out. They're difficulty in clearing the secretion. So these are the patients that will require intubation. They develop progressive, CO2 retention, and they develop hypoxemia. and the chest X-ray is already show widespread atelectasis or also aspiration. So these are the patients that will require intubation. So I think the previous speaker also, I think there's a question of whether you want to give an IV or whether you want to give invasive ventilations. It all depends on many factors, the clinician's experience, whether you have the support and what kind of setting that you have, or whether, how often can you manage the patient. So NIV is good. We if possible, we are trying to avoid the use of invasive intubation. NIV is something this is good, but you need to make sure that the patient has a full GCS and the patients at least partially or at least able to manage their secretions. So this is something that you might want to consider. That's why when you want to intervene the patients, when the patient is impending myasthenia crisis, when you put them on NIV when they are still awake, and when they have a better ability to manage their own secretion, you put them on NIV, you might be able to prevent them from going into invasive ventilation. So you intervene early when they are still okay. So you might, by doing so, you might able to reduce the duration of ICU stays and hospitalization. And although some of them they might have a bit of bowel weakness, but as long as the secretion is still manageable, you monitor them with the NIV carefully. It is still something doable. It's not something which is entirely not doable. So, but if you think that the patient can't manage with the NIV, you might want to give them invasive intubations. Now, all the criteria, as I mentioned earlier, mainly for those critically ill patients. And I think the previous speaker has also mentioned the use of whether depolarizing agent and non-depolarizing agent. So depolarizing agent is not the best, your succinyl choline itself has. You probably need to use very, very high dose, 2 times, 3 times the normal dose, to get them into, paralyzed for you to intubate. It is less sensitive because for myasthenia gravis patient, they already have not many acetylcholine receptors available. So you giving them the depolarizing agent is not going to be extremely effective. And in fact, you need to you give high dose. The problem with giving high dose is it takes very long to clear inside your body, so that they will remain paralyzed for extended period of time. We're trying to avoid that. It's not the best agent that you can use. Non-polarizing agent, it's good. You probably use a lower dose, and some of them things that because myasthenia gravis is very extra sensitive to this non-depolarizing agent, so you probably use just half the dose or even 1/3 of the dose as a beginning, and you see how the patient go as you intubate. But of course, as what the previous speaker has mentioned, there are many papers nowadays on myasthenia gravis intubation that do not use paralytic agent. Okay, just give them a bit of sedative agent, a bit of painkillers. You can just proceed with the intubation, and majority of the cases are successful. You probably can avoid the use of paralytic agent if there is possible. So you want to start treatment of the infection or the precipitating event. If you have got electrolyte imbalance, you correct them in the A&E, and you see that the chest X-rays or the septic workup or your preliminary blood actually shows infection, you start them with antibiotics straight away, to kickstart with the treatment of the precipitating event. So many of them will come to you with acetylcholine inhibitors, nomestinon or pyridostigmine that they are taking. So if possible, when the patient go into crisis, the role of this medication is very, very little. It doesn't really help. But in fact, when you give them this kind of mestinon, it causes them to have hypersecretion. They complicates the airway management and they aspirate more. So it is not something that is very, very useful. But it is recommended that if the patient go into crisis, the pyridostigmine you can just temporarily hold it first, because when you give them high dose, also you might even have a risk of getting them into dysarrhythmia. So it is something not advisable to give, because we have seen some of the patients with myasthenia come to us, because they are getting weaker over time, So when they see the doctor earlier, ask them to increase the mestinon, increase this, and at the end of the day, it didn't work, and then complicates the whole treatment process. So after that, when you refer to a neurologist, normally we will start them on corticosteroid, immunoglobulin, plasma exchange to get them out from the crisis. But be aware that normally we do not give steroid immediately during the myasthenia crisis, because as I mentioned, it may precipitate the crisis even more. So what we do is we will recommend steroid use after you have started them on IVIG, and also, sorry, is a typo here, IVIG or also plasma exchange. You treat them first when they're stable, only then you top them up with the corticosteroids. Right. So this is what I mentioned. First, you actually treat the respiratory problem, you treat the bowel problem, you support them, you give them ventilation if they need, and you stop the cholinesterase inhibitor with the pyridostigmine, and subsequently you proceed to give them acute treatment, whether you give them plasma exchange and also IVIG. All right. This is what I mentioned about this, cholinesterase inhibitor, pyridostigmine. It's good for a first line. When the patient is well, they come to you, some doses, you can put them on a myasthenion or cholinesterase inhibitor. But it rarely actually, induce complete or sustained benefits of a patient with MG. Probably you need to give them 2 to 3 times a day, or even 4 times a day, just to maintain them symptoms free, and it do not actually affect the disease progression. It's kind of like when you have, it's similar like when you have fever, I give you a Panadol, the kind of thing. So it is not sufficient, okay, to give you adequate management, especially when the patient's having this kind of progressive deterioration, where it is probably just going to complicate things more. Again, I mentioned plasma exchange, IVIG, is the standard treatment that we give it to the patient with myasthenia gravis. The standard dose of IVIG is 2 grams per kilo over 2 to 5 days infusion. As you can see from here, for comparing to placebo, among patients who have worsening but not in crisis, worsening myasthenia gravis, you can see that those that are receiving IVIG do better in terms of their quantitative MG score outcome in the patients with myasthenia, if you treat them with IVIG comparing those that receive placebo. So which one better, IVIG or plasma exchange? The result is the same. There's no difference between these two. There's same efficacy, same duration of effect. So there's no difference. You can choose whichever that you have in your own center, depending on your availability. And of course, some of the patients have IVIG is much more expensive than doing plasma exchange, and also again it's also depends on what type of plasma exchange that you do, with what kind of facility that you have. Again, there are many factors, but in terms of efficacy, they are the same. In terms of the duration of effect, they are exactly the same. Okay. But in what condition that you might want to consider the use of plasma exchange, and if you know that this patient have a MAST MG, MuSK. So we know that typically MAST MG, they have this IgG4 related antibody activity that is resistant to IVIG. So if the patient that comes to you with a MAST MG in crisis, you give them IVIG, is less likely going to work comparing you doing a plasma exchange. So in this kind of patients, we recommend the use of plasma exchange, and probably combined with the steroid later when they are better, especially for the patient with MuSK, which is the muscle specific kinase MG. So 20% of the refractory MG patients, 20% of the patients are refractory to all this treatment. You might need to give them a few courses of IVIG, a few courses of plasma exchange, in order to get them out from the myasthenia crisis. But this one normally does not involve so much of the A&E. I'm telling you is, some of the patients just keep on coming back to you, A&E because of MG crisis, and these are the patients that we label them as a refractory MG. Okay, they might need third-line treatment, for example, cyclophosphamide, rituximab, serial plasma exchange, serial IVIG infusion. Okay, I'm not talking about this because these are more specialized treatment for refractory MG. You can use cyclophosphamide, rituximab, monoclonal antibody, and etc. So just a little bit with regards to thymectomy before I finish. So I mentioned thymectomy is, of course, it is not something that you are going to do it in the A&E for a patient with a myasthenia crisis. But thymectomy is proven to be beneficial for patients with myasthenia gravis, especially those with antibody positive young patient of disease duration of less than 5 years. So it is proven to reduce the need of the steroid and also the mean functional score of the patient with myasthenia gravis. Overall, it improved outcome and it reduced the need of a steroid dose. So, but the thymectomy is the potential trigger for crisis. So, patients with thymectomy going in, my MG patients, they go in for a thymectomy. It is actually a potential trigger. It is something that you need a very good pre-op optimization before they're going into thymectomy, because some of the patients, they're on treatment, they go into thymectomy, and then after 1 week they discharge. Then a few days later, after discharge, they come back to you with a crisis, because the thymectomy itself is something that might precipitate myasthenia crisis. So just 2 special considerations: pregnancy. Pregnancy patients go into crisis. Sorry, patients with MG in pregnancy can go into crisis, especially during the first trimester and also then during postpartum. So this is because when you when you plan for pregnancies, majority of the immunosuppressant that the MG patients take are not advisable. So majority of the doctors will stop the immunosuppressant or sometimes even steroids. So by doing so, you actually cause them to have higher risk of going into decompensation. And because the pregnancy itself is also a physiological stress, and especially when during delivery, and for those that require cesarean section. So these are all factors that can trigger the patient into crisis. Of course, COVID-19 infection. 40% of the MG patients who are infected with COVID-19 will need some form of rescue treatment, whether it's IVIG or also plasma exchange. And despite that, mortality is 24%. And we have lose quite a number of patients, very well MG patient previously on monoclonal antibody, but when they get COVID-19, they becoming very, very severe. They decompensate within days. And one of my patients even died in A&E. It's that kind of response, which is very, very drastic. So this is something that we want to look for. Yeah. So meaning that initial rescue of the patient in the A&E is extremely important, especially for those patients that have got a severe infections with the underlying MG. Okay, in summary, myasthenia crisis is a clinical diagnosis. No ABG can diagnose myasthenia crisis for you. Clinicians should consider myasthenia crisis in patients presenting with muscle weakness and also a respiratory muscle compromise. So focus in ED should be on the initial management of the respiratory support and also identify of the trigger factors. And cross monitoring them, okay, respiratory function until you hand over the case to either a primary team of neurology or when the patient is going to the high dependency or ICU unit. So early respiratory intervention should be considered. Of course, we want to do a kind of like more elective kind of intubation rather than having an emergency intubation, because emergency very often comes with some form of complication. All right. With that, thank you. If you have any questions.
Thank you, Dr. Hiew. That's very comprehensive talk, and I think it's also beneficial also for the physician in training, not only for emergency physician. So okay, we can start with the question. Are you okay with that, Dr. Hiew?
Yeah.
Okay. So we have a question from Dr. Nasrina here. So can myasthenia gravis present with isolated dysphonia or dysphagia without any other muscle weakness?
Yes. Yeah. So I have one of my patients that I think referred to me last year from the ENT, and very interesting case. She went everywhere, saw GP, saw I don't know what who she saw. I saw a few ENT until she came here and she saw one of my ENT surgeons that having this dysphonia. Very interesting case. She had absolutely no other MG symptom at all, only the voice. And initially, I didn't believe her also. I thought she was just, don't know, some throat problem or whatever, dysphonia and the worst thing is because she's a teacher. So she need to teach, and Morning when she started teaching, she was okay, and then until afternoon she got no voice to teach. And when I put her on Mestinon, a week later she came back to me, her voice become normal. And subsequently, of course, she had she got a thymoma, and we resected the thymoma, and she's now very well. Yeah. To answer the question, yes, very, very interesting case. Even I myself didn't believe that. Sometimes you patient is whether they are playing with you or whatever, but it's true that it's very interesting.
I think, but Dr. Hiew, you agree, right? So such isolated is actually not common.
It's very very uncommon, Ashraf. It's extremely uncommon.
Yeah.
You definitely will see some of them will come to you with a little bit of ptosis here, a little bit of weakness here, a little bit. But this one is just she has seen so many ENT because she only have the voice problem. In fact, the barium swallow and all these things, everything is normal. It's very very interesting.
Yeah. So I had to send me the referral, but it's actually a motor neuron disease. Basically, it's very uncommon.
It's something that you want to look out for, but this one is very very interesting.
Sorry, Ashraf.
Yeah, no worries.
Because you mentioned that I had one patient. He's a Sabahan, 30 plus. He's a lorry driver. He came only with nasal speech and also difficulty in swallowing, gradually worsening. So the ANT scoped him and said there's nothing there. And patient was admitted, and finally patient was put on trial of Myasthenia Gravis medication, but was discharged to HKL. So I do not know what is the outcome of the patient, but thank you for sharing, because we're thinking just to put as a interesting case report for conferences, so that people would neglect the possibility of patient coming in with this situation without having any muscle weakness per se.
Yeah,
thank you.
But it's not common. It's very rare. It's not common. But it's good that they have seen the ENT, because the first thing that you want to clear is whether they got something there, NPC or something like that. They're sitting down there. This is something that you want to be sure first. Yeah.
Sure.
And the person also asking about what is your advice in terms of if the patient comes in this department, what the usual routine neurological examination. Just now, I think you share about the examination, neck muscle just now. Yeah, I personally feel that the respiratory you can just assess by neck flexion. So yeah, what is your short advice for during the
ask them to count. Take a deep breath and count. And I count to at least 30, 40 or 50 and see how much they can count in one breath. So for me, that is a very good way of monitoring them. And because sometimes you do chest expansion, when you examine the chest, sometimes it doesn't give you a very yes, it's true that you probably can know that the chest expansion is a bit less, that kind of thing, but you can't monitor them objectively. So you want to the main aim is you want to monitor the progress over the next few hours or the next few days. So you want something objective. So counting is actually something very, very good. Yeah.
Really agree. Thank you on that. So I go to Dr. Gurjit first, Dr. Nashinam. There's a question from Dr. Gurjit about he was mentioning about Mestinon, methylprednisolone, and steroids are readily available in the emergency department, and they don't have IVIG and plasmapheresis. Maybe you want to explain on that in the emergency setting?
Yeah. So if the patient is already going to crisis, and if you already preparing to intubate the patient, you don't give Mestinon, the pyridostigmine, and you don't give steroid. It's not going to help. You just refer to the primary team, and then they ask them to do the definite treatment, whether IVIG or plasmapheresis. But some of the patients, they have the international consensus of MG management guidelines. They are having this what I call impending crisis. So they are getting a bit weaker, but they're not getting worse. They're not requiring immediate, respiratory intervention. So these are the patients that you can consider giving them steroid. I have a patient that comes to me like that. So what I do is I start them on prednisolone, 10 milligram. Second days, after 2 or 3 days, I increase to 20. 2 or 3 days, I get to 40. For those patients that are not so severe, you can get them out from steroid. Yeah. So these are how, but you do not give them straight high dose. You slowly you taper them, you monitor them, and you see how they go. They actually can come out of it. Yeah, the steroid actually do have some good in terms of for patients who have myasthenia worsening. But if they're already in crisis, I think you hold on first. You give them the IVIG, give them the plasma actions first.
Yeah. And at the same time, I think we just need to emphasize again. You don't have the medication, but airway management is one of the powerful things in terms of the MG mortality. So you can prevent that by managing the airway. Yeah. And then now back to the Nashina, when the patient come with the called MG crisis, how frequent is chronologic crisis, and maybe you can share a bit how then the tips to recognize one.
Okay, this is a $1 million question, Nashina, and honestly, patients with MG that comes with cholinergic crisis, I think in my experience is zero. I have not seen anyone that come with cholinergic crisis. It is something that I have done some research recently. I mean, a couple of years ago on MG patient on research on cholinergic crisis. If you were to do search on the PubMed and you see very little report on that. In order for you to get a cholinergic crisis from a pyridostigmine treatment in a patient with MG, it is estimated that you will need probably up to 200 milligrams a day. Yeah, so in order for you to get that kind of crisis, in fact, when I see a cholinergic crisis, I probably wouldn't think of myasthenia. I will probably think of whether this patient have got organophosphate poisoning. I think this is something that we see much more common. You know, they come to you with this organophosphate poisoning. You know, when I was MO and houseman in Tolo Intan, I still remember. Oh, that is kind of like a bread and butter of medical department of these people drinking organophosphate and come to you with cholinergic crisis. But for MG, honestly, out of so many years of my experience treating MG patients, I have not come across with anyone that comes with cholinergic crisis.
Yeah, so that's interesting, Dr. Hiew, to mention that. I think after your lectures now, I totally agree. Mostly is MG crisis itself alone. But sometimes because we refer late when the patient already being managed by the GenMed and ICU already starting on the medications, right? So sometimes iatrogenic. So the patient is not ready yet, as Dr. Hiew shared just now. Septic still and called on ventilator, MG crisis still on board. Immediate commencement on the, sometimes it's slightly on the higher dose compared to their size. Then the patient will have MG crisis.
Yeah, because they always think that giving them more is good, you see.
Yeah.
Actually, probably, in fact, it causes more problems.
Correct, yeah. Okay, so we have an interesting question over here, but I think I can combine them with Nadrul and Dr. YY. So basically, how we basically recognize, how we differentiate between MG and maybe this is stroke-like symptoms. So maybe a short note on that. And do you then use ISPEC test or this is maybe fatigability, Nadrul, the UpGaze test for the MG in ED.
So how to confirm MG in ED? So I think it all depends on what kind of symptoms the patient present to you. If the patient present to you with ptosis, and if the patient present to you with double vision, diplopia, ophthalmoplegia or ophthalmoplegia, and you always have to entertain whether this patient actually have a posterior circulation infarct, or whether this patient have something happening in the midbrain, the pons, the medulla. So if you're not sure, you do a scan, you do an MRI, and you should be able to tell. But of course, clinically, if you do not have an MRI, clinically, normally the symptoms of MG doesn't come just like that. I think, Ashraf, you know, when you have a stroke, suddenly the patient just have the symptom. It's a very acute kind of presentation. MG normally comes with, you know, they probably have a ptosis for a while, a little bit of double vision, few days, you know. Then only they become more bulbar, not the kind of thing. It's not something which is within split seconds. So history is very, very important in terms of you establishing the diagnosis of MG. But stroke is something which is very acute. Stroke will normally comes to you, and if the patient have ptosis, double vision, and it comes with limb weakness like unilateral, you know that this is more likely going to be a stroke because brainstem involvement, or even they have got reduced conscious level. You know that this is more to the stroke rather than to MG, because MG, in order for you to involve the limbs, it takes time. In order for you to involve the respiratory muscle, it takes time. And very rarely the patient comes to you lower limb weakness. It's many upper part of the body. So these are the features that you can find in the patient with stroke and also MG. So whether there's any role ice pack, yes, if you want to do an ice pack, yeah, you can. And if you see there's an improvement in terms of the eye opening, then yes, it's suggestive of fatigability. But be aware that, you know, even some patients that have got a ptosis for other reasons, for even posterior circulation stroke, they even, you know, some patients with some thyroid or whatever, when you do an ice pack test, you might subjectively see some improvement. But just be cautious when you do this kind of test. Fatigability test up gaze is something that you can do, something which is quite specific. But if it is bilateral, it's easier for you to establish, because you don't get stroke for bilateral ptosis or bilateral ophthalmophagia kind of thing. But when it is unilateral, sometimes can be a little bit more tricky. Then you probably have to see whether the patient have any other sign for you to know this one is more to MG or more to strokes.
Thank you. I totally agree. And the last question for today, so this is the last question, so we need to read this one from Nazrul just now. So any special ventilator setting specific for MG crisis patient?
No. So if the patient remains conscious, can breathe on their own, you put it on CPAP. Or, you know, if the patient cannot and you want to rest them, you want to paralyze them, if the patient have no breathing effort because so weak, and then the tidal volume is not good, you want to put them on SJMC. There's no specific setting. All depends on how the NS assess them and how is their breathing effort. But normally, if the patient is very weak, they might need SJMC to take over the breathing. But let's say if the patient is getting better, you slowly convert them into CPAP, and then not let them breathe, because when they breathe better, you expand the lung and then you reduce the atelectasis and can clear the circulation better. Of course, it all depends on how the patient responds to your treatment.
Thank you, Dr. Hiew. So yeah, thank you for the participants also for being interactive. And thank you again to Dr. Hiew for the very comprehensive lecture. And I also learned again today. So usually I just update myself with stroke, and now coming back to neurology, today Myasthenia Gravis. So I hope everyone enjoy the lectures. So we started just now with Dr. Gurjit, and now with Dr. Hiew, and the usual manner. I think before we end, Dr. Nasuna, right? We want to take a picture together.
Yes, the usual.
Yeah.
And the recording first.
Okay, so can you on your camera?